Hello, my dear friend. I'm so happy to be with you, and I would like to thank you so much for the second webinar of Institut La Main in Paris. You know that Institut La Main has been created a long time ago by Raoul Tubiana, and we were a pioneer in the creation of a group of surgeons dedicated to the hand surgery, but not only the hand, all the upper limb, because some surgeons works only for the shoulder, personally for the wrist, etc., etc. As you know, or maybe you don't know yet, but I'm retiring in a few days. It's time for me to stop the surgery, but you're not going to get away with this, because I continue teaching and even do more than now. So you'll still see me for a long time. So today we have a special webinar about the Kienböck disease, which is a very incredible pathology, you know. And since the description by Kienböck more than 100 years ago, it was a challenge to treat that, and we'll have to see how we can manage to this pathology. So I asked to Lorenzo Merini, who will be my representative, to take in charge of the discussion and everything, so we can start. Thank you very much, my friend.
All right, thank you, Christophe, for this nice introduction and for the kind words. Christophe is actually in abroad and with unfortunate limited internet connection, so I will do the honors of introducing our wonderful team today. And we have the pleasure to have as guest speakers Greg Bain from Australia, Simon McLean from New Zealand, and we'll have a topic with Joe Yupley from Korea. And of course, we have also with us Mathilde Gras and Ahlam ARNAOUT from our team at the Institut La Main in Paris. You are very numerous in the audience today, so thank you for your interest. Don't hesitate to ask your questions through the questions dedicated button, which is right next to the chat, and we will do our best to answer them. We have 2 breaks for questions within the next hour. And now, without further ado, let's get started with the first speaker, which is Ahlam ARNAOUT on the current bibliography on Kienböck's disease. Ahlam, when you're ready.
Thank you, Lorenzo. Good morning or good afternoon to everyone. Welcome to everyone for this first lecture. Christophe Mathilin asked me to talk about some current data we can have from the literature about Kienböck disease, and we can also consider it as a short introduction. So we all know Kienböck disease was first described more than 100 years ago, and since then many procedures have been described, and now the optimal treatment according to the stage remain controversial. So if we focus on the literature, we can find a huge number of publications, and just in 2020, Kienböck disease was cited more than 100 times. And we can easily consider the past decade as the modern era. What do we know about the etiopathogeny? We used to consider the Kienböck disease as multifactorial with mechanical factors, mainly the negative ulnar variants and vascular factors. But if we focus on the recent literature, it's not that clear, because we have inconsistent data, especially for the negative ulnar variants, which some studies that do not support the exact correlation. What is very interesting is that those new biomechanical and vascular patterns, and our colleague today, Simon McLean, is going to will give a lecture about this interesting topic. What about the diagnosis? We all know the Lichtman classification in 4 stages, which is based on the radiographic and MRI findings. And in 2010, 2 or more stages were added, the Lichtman 0 and the Lichtman 3C, making this classification much more accurate. We have also the advanced imaging with the gadolinium-enhanced MRI with the Schmidt classifications, and which is used in a new treatment algorithm, new current treatment algorithm, and we'll see that later as well. And of course, we have the arthroscopy, which allows a dynamic cartilage lesion staging with the Bain and Beck classifications, which introduced the notion of functional articular surfaces, and we'll have also a lecture about this later. For the therapeutic option, we use to indicate the unloading procedures and LUNATE revascularization in the early stages, and the salvage procedures in the stages up to 3A. But we'll see that often this red boundaries is not that clear. And it's quite interesting to see what are the current practice about Kienböck disease. We have this recent interesting survey of hand surgeons that shows that the radial shortening is the most preferred technique among hand surgeons. But what is most interesting is that 90% of the hand surgeons consider the Lichtman classification and the owner variants are the most important criteria to decide the treatment. And it's very interesting to see that in 2015, the majority of the surgeons do not consider the arthroscopy of a key step for diagnosis and treatment. And maybe today the results will be different. For the LUNATE unloading, the radial shortening osteotomy is considered one of the gold standard in the early stages, and some studies showed good results for the advanced stages. But there are concerns about the DRJ congruity and the instability of the DRJ. We have some very recent interesting works about selective shortening, and especially this works from Emmanuel Camus and colleagues. And I thought Emmanuel was in the assistant. So hi, Emmanuel, and thank you for the picture. This technique shortens only the radius facing the lunate. So we have 11 cases published in 2019. And what is very interesting is the improvement of the MRI aspects and the MRI aspects, and there is no worsening of lunate shape and no evolution to collapse at the 7 years follow-up. So it's very seducing and interesting procedure. We have also the very distal wedge osteotomy, which is with the wedge apex distal to the conventional technique. It's also very seducing, but we have also only 6 patients with a very short follow-up of 3 years. For the capitate shortening, the main concern is about the overloading of the ST joint, and some studies show carpal collapse in all patients. And the partial capitate shortening appears as a very interesting alternative solution. The principle is not to disrupt the scaphocapitate joint, and it doesn't affect the mid-carpal and scaphocapitate dynamics. We have a number of recent studies that all shows excellent revascularization rate on LUNATE, but the series are very short and very small, and the follow-up are very short, so we can conclude anything. For the radius core decompression, is a very simple procedure which gave good clinical outcomes, but we have inconsistent data about the disease progression. So we can't conclude anything on this neither. The open lunate core decompression is very simple. The 20 cases published in 2011 with an improvement of the functional parameters. It's not recommended in the stage 3B. And what is very interesting is the arthroscopic lunate core decompression, which is a very seducing technique, simple, and it is described and recommended in the arthroscopic grade 0 in number of recent papers by our colleagues present today in the webinar. So we can conclude that the selective shortening are very encouraging, and we have a kind of lack of data for core decompression. But the lunate core decompression arthroscopy is very seducing procedure. For the vascularized bone grafts, we know that the pedicle vascularized bone grafts are one of the first treatment options for the stages up to 3A with satisfactory results. And we can find that the 4+5 extensor compartment artery bone graft is the preferred technique among hand surgeons with the survey of the other survey of hand surgeons. And it is mainly used for its favorable properties, especially the wide diameter of the pedicle. And we have a recent, very interesting review that shows a good global revascularization rate, but no technique has clearly showed its superiority. We can also say a word about the mixed technique, pedicle graft plus leveling procedures, especially this technique described by Christophe Matulin, and Mathilde Gras will give a lecture about this later. And there is a growing interest around the free vascularized bone grafts because we can shape those grafts in any configuration. Then we can use them as osteochondral grafts in the advanced stages to reconstruct the lunate cartilage with a good consolidation rates. And the results were promising in scaphoid non-union treatment. So very interesting. So for lunate salvage procedures, we feel that everything has been tried: lunate excision plus tendon interposition, pyocarbon, silicone, titanium, arthroplasty, but we can't conclude anything on those procedures. We can say a word about vascularized pisiform bone grafts. It's known as Sapphire's procedures, 51 cases published in 2010. And we have a recent long follow-up series that shows the main concerns are about the carpal collapse and the stability of the implanting bones. I will have a lecture about our colleague who is going to talk about the pro and con of this technique later. For lunate excision, single lunate excision, it's not that popular. It used to be considered as an inadequate treatment because of the progressive carpal collapse. We have a recent study that shows satisfactory functional outcome despite the carpal collapse, and a very recent biomechanical study that concludes the arthroscopic excision could potentially prevent for kinematic changes. And Lorenzo Merlini will talk about this possible technique of the future at the end of the webinar. So stay with us, please. For the salvage procedures, the limited intercarpal fusion, the STT and the scaphocapitate fusion showed a significant decrease load on lunate, but the main concern is about the high complication rates with those procedures, the evolution to arthritis. And we have some recent studies, the STT, about STT at scaphocapitate fusions, but we can't conclude anything about those studies. What is very interesting is the arthroscopic assisted procedures, especially the scaphocapitate, radioscapholunate fusions, and they are described and recommended in the recent papers, and our colleague will give lectures about this later. We have also some anecdotic papers, for example, the 3D printed lunate for Kienböck disease, but we have to wait for definitive results. The treatment algorithm is very in the trend. We have the Bain-Schmidt-Lichtman treatment algorithm, which is very accurate and relevant. It is based on the advanced imaging and the arthroscopy. And we are very lucky today because Professor Bain will talk about this. It is a very interesting patient-based and surgeon-based treatment algorithm. We have other treatment algorithms proposed today, but they are not so different from the first one. So if, as a conclusion, you can say that from the literature, there is no real evidence-based consensus about which procedure is the optimal one in which stage, because we have a small series, most of them are level 4. But what we can say is that the advanced imaging and the arthroscopy allows plausible diagnosis and treatment algorithms nowadays, and the Kienböck disease appears as the primary